Nephrotic syndrome. Nephritis literally means the inflammation conditions in the kidney. Nephritic inflammation may occur in association with the infection, allergic response to the medication, systemic autoimmune disorder, toxic exposure. Kidney may be one of many organs or only organs involved in the inflammatory disorder. Inflammation with enlargement of the kidney is often associated with the point tenderness over the flank. And exquisite costovertebral angle tenderness and requiring the gentle palpations for the diagnosis. Nephritic syndrome can be further subdivided depending on inflamed structure within kidney, including the glomerulus, tubulointerstitium, vascular. On the time of course of progression of inflammatory process, which may be the acute, subacute, and chronic. Glomerulonephritis classifications of the GN has been challenging because of overlapping features of infections related and immunological mediated pathology. GN is associated with the hypertension, volume expansion, and the abnormal urinalysis. ভলিউম এক্সপানশন, জিএন হচ্ছে জিএনের হাইপারটেনশন থাকবে, ভলিউম এক্সপেনশন থাকবে অ্যান্ড অ্যাবনর্মাল ইউরিন অ্যানালাইসিস। ভলিউম এক্সপানশন ম্যানিফেস্টেটেড হচ্ছে ইডিমা থাকবে, হাইপারটেনশন থাকবে। তাহলে হাইপারটেনশন জিএন, গ্লোমেরুলোনেফ্রাইটিসের মধ্যে থাকবে ইউরিন ভলিউম এক্সপানশন, যেটা হচ্ছে হাইপারটেনশন থাকবে, ইডিমা থাকবে। ইন দ্য চাইল্ড অ্যাসাইটিস মে ডেভেলপড, and in elderly restlessness, anxiety may first sign of incipiented pulmonary edema. যদি হচ্ছে অ্যাংজাইটি রেস্টলেসনেস থাকে, অ্যাকিউট পালমারি ইডিমাও হতে পারে। ফার্স্ট সাইন অফ দ্য ইনসিপিয়েটেড অ্যাকিউট পালমারি ইডিমা। There may be orthopnea at night or dyspnea on exertion, with and without significant peripheral edema. Acute GN is usually associated with low urine output. Acute GN হচ্ছে low urine output, oliguria নিয়ে আসবে, at a time complete anuria, and low urine sodium content, concentrated urine resulting in retention of the salt and water. It is vital to observe the pan-urological sediment diagnostic GN. The presentation may be the acute and subacute, occurring over the days and weeks in the post-infection GN, as the chronic smoldering process with excoriations progressions to the chronic kidney failure over the severe month to year. The pathology correlate of these presentations, the relative amount of acute inflammation, proliferation, and necrotizing lesion in the renal tissue versus chronic sclerotic atrophic findings on renal biopsy reflect acute versus chronicity of the disease. Therefore, in this progressive destructive condition, early diagnosis is critical, and treatment for acute reversible disease should be instituted as quickly as possible. The evaluations of finding on history, physical examinations, and urine analysis in narrowing the diagnostic possibility for specific etiology of glomerular syndrome is demonstrated. And the nephrotic urine analysis shows the hematuria, proteinuria, cells and clump on the cells, cellular crust, span of the urine sediment. The cells in the urine are usually a mixture of the red cell, hematuria, and inflammatory cell, pyuria, and PMN. polymorph nuclear leukocyte. Microscopic hematuria is invasive to naked eye and opposed to microscopic hematuria, which is often described as a coca or tea-colored urine by hemoglobin entering an acid urine forming the hematine. The process of urine erythrocyte crossing the glomerular membrane barrier causes the red blood cells to become misshapen and dysmorphic. And this unusual in this nephrotic syndrome to see the blood clot or gloss hematuria is termed to use for overtly blood red urine that is often accompanied by dysuria and characterized by trauma other syndromes of lower urinary bleeding. However, in episode of immunoglobulin A nephropathy, glomerular hematuria is often crossed as red blood cell reverse diagnosed glomerular basement membrane. Post-infectious glomerular nephritis. In post-infectious glomerular nephritis, the classical example of acute GN immune response informed the formation of antibody bacterial antigen complexes within the circulation, usually 10 days to 3 weeks after infections of the pharynx or skin. Impetigo hote pare. And by specific nephrotogenic strain of the beta hemolytic group A streptococcus. 10 days to 3 weeks the depositions of this immune complex amplifies and activate the complement cascade, causing the intense inflammatory response that accounts for active sediment in the urine and decrease the circulating C3 level in the blood. Cellular proliferation is intercellular filtering the surface area, causing a pre-renal retention of the sodium, water, oliguria, and sometimes anuria. Pathologically, the proliferation disrupts capillary blood flow, hence the descriptions of bloodless capillaries for these conditions. In the general population, the incidence of PIGN has decreased given the widespread availability of antibiotics, especially the penicillins and sulfa drugs. At the time of presentation with renal finding, there may be no ongoing infection, but rather a continued immune response to a specific bacterial antigen. Antibiotic may not be necessary if the infection has resolved. Evidence indicating the initial infection may still be present in the form of titers of streptozyme, anti-streptolysin O, anti-desoxyribonuclease B. Upon deposition of circulating immune complexes bind and activate C3 complement which with other cytokines, causing a proliferative pattern of the injury with subendothelial glomerular depositions. Taken together, there is increased clearance of total hemolytic complement and C3, causing the hypocomplementemia. Over time, subepithelial deposition known as HUM developed and proteinuria increased. As subendothelial deposition cleared, nephritic signs disappear. Infective endocarditis, both acute and subacute, may also result in circulating immune complexes even while the patient remains on antibiotic treatment. These glomerulonephritic conditions are also recognized clinically by low C3 complement level in the blood. In PIGN, the post-infectious cases should be distinguished from cases of infection-associated GN that occur during an ongoing infection such as streptococcal abscess, osteomyelitis, empyema, which are treated with antibiotic, and purulent drainage are characteristically associated with the IgA deposition in the glomeruli. PIGN is also to be distinguished from symphangitic hematuria, another glomerular syndrome that frequently produced a heavier excretions of red blood, which may appear to the patient as a frightening hemorrhage. The patient may present with this concern, so it is important for the clinicians to recognize that as little as 10 to 20 ml of blood will return a liter of the urine blood. Symphangitis hematuria, usually occurring simultaneously within 1 to 3 days into and viral pharyngitis, is most often related to IgA nephropathy rather than the PIGN. Though C3 complement is deposited in both PIGN and IgA nephropathy, only PIGN is associated with low complement level in the blood. IgA nephropathy, one of the leading causes of renal failure worldwide, is common type of the GN that is caused by the mesangial deposition of the C3 binding to access the galactose deficient IgA1 immunoglobulin, and this result in damage to basement membrane manifesting as hematuria and renal insufficiency. Although IgA nephropathy is a common disease, particularly in Asia, data on the prevalence are often based on clinical assumptions rather than the kidney biopsy, and therefore our inaccurate treatment is based on each patient personal presentation, but all patients need management of hypertension and proteinuria, often with the angiotensin 2 inhibitor. Because of its associations with viral infections, IgA nephropathy has historically been treated with the removal of lymphoid tissue with strategies such as the tonsillectomy. Other treatments have included the fish oil corticosteroid. However, recent advances in understanding the lacting and alternative pathway of complement have led to investigations of targeted therapy based on kidney biopsy showing IgA1 and glomerular deposition of mannan binding lactin, which occurs 50% of the patient with IgA nephropathy. Complement blockers, B cells therapies, and plasma cell therapies are currently either in use or the being further investigated to treat the patient with the genetic predispositions for high level of galactose deficient IgA1 in order to antagonize the development of auto antibody to abnormal IgA and to interfere with the pro-inflammatory complement binding to lethargic mesangial deposition of immune complexes. The avacopan, a selective IgA receptor inhibitor effective in treating the anti-neutrophil cytoplasmic antibody-associated vasculitis, lower proteinuria in IgA nephropathy. The U.S. Food and Drug Administration has recently approved an oral drug endothelin 1, an angiotensin 2 receptor antagonist for the reductions of the proteinuria. Endothelin 1 and angiotensin 2 receptor for reduction of proteinuria in the adult and primary AGN high risk for progressions. This individual typically um, urine protein creatine ratio 1.5 gram and decreases the GFR. The patient with the chronic kidney disease, either micro or macro hematuria as sign of the disease, has been less likely to receive a renal biopsy than patient with azotemia or proteinuria, increasing the appreciations that the patient of IgA nephropathy have a more rapid GFR decline to end-stage kidney disease has encouraged greater use of the renal pathology to guide a more aggressive management strategy. Attention to risk factor and advance in development of novel pharmacologic approach based on the better understanding of the pathologies of IgA nephropathy have led to greater judgment to perform a renal biopsy for diagnosis and treatment, increasing appreciations that patients with IgA nephropathy, particularly those African Rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis is a syndrome arising from a variety of the causes. Pathologically, it is associated with proliferations of the glomerular parietal epithelial cell inflammatory cell known as the cellular crescent and surrounding the compressed capillary, reducing the infiltration surface area. Over time, the crescent become fibrotic and atrophic with the global loss of glomerular tract. When greater than 50% of glomeruli are affected, this highly obstructive process usually leads to global glomerular sclerosis. When less than 50% of glomeruli are acutely affected and only part of each the glomerulus is involved, a condition known as the focal and segmental necrotizing gene development with and without crescent. When such lesion heal, focal segmental glomerular sclerosis result, and this pathological finding on biopsy must be distinguished from the primary podocytopathy and from the adaptive changes seen in the most progressive chronic kidney disease. Recognitions of the RPGN and the choice of appropriate therapy are extremely important because if left unchecked, the capillaries can lead to complete irreversible loss of the kidney function as well as the fatal pulmonary hemorrhage in associations with the lung vasculatures. In the case of RPGN, one may see the typical sign of the nephrotic syndrome, usually with subnephrotic proteinuria, although other clues to diagnose may be present in pulmonary renal syndrome, where the patient may present with hemoptysis, interstitial lung disease, epistaxis, and upper airway symptoms of sinusitis and nasal congestions. Blood testing, including at least 3 necessary the anti-neutrophil cytoplasmic antibody test, particularly the anti-proteinase 3 antibody and anti-pyeloperoxidase. Myeloperoxidase is diagnosed for the post-immune disorder of systemic vasculitis such as the glomerulus vasculitis, vaginal granulomatosis, giant cell arteritis, microscopic polyangiitis, which are particularly associated with the pulmonary and upper respiratory disease. In ANCA positive disease, the kidney and peripheral vessels were targeted of autoantibody which attracted complement and result inflammatory vasculitis. Church-Strauss syndrome, which is both glomerulus and eosinophilic, is the vasculitis associated with asthma. By contrast, a positive test for the anti-GBM antibody with and without positive ANCA would be consistent with renal limited anti-GBM disease. One key distinctions between the ANCA positive vasculitis and anti-GBM disease is that the vasculitis may recur and even subclinical historicals at different time, whereas the onset of the anti-GBM is usually a single acute fulminant presentations that must be diagnosed rapidly with ANCA and anti-GBM studies, renal pathology, and terms properly with the plasma exchange followed by the anti-inflammatory medications and cyclophosphamide rituximab as the immunotherapy to preserve the kidney functions. A positive anti-GBM test when associations with the pulmonary hemorrhage is consistent with the good pastor syndrome, which is disorder most often seen in the elderly populations or young male who smoke or have a history of inhaling the hydrocarbon solvent, and not infrequently both anti-GBM and ANCA are present with pathology showing post-immune disease, but the proposed role of the ANCA is to accuse the GBM epitope. And this disorder should be treated in the same way as the ANCA itself. The goal of the plasmapheresis is to remove all the GBM autoantibody, which may take weeks to months. The circulating IgG anti-GBM complexes in situ with the C3 complement is directed at the epitope in the alpha 3 chain of non collagenous domain of type 4 collagen in the basement membrane. This occur in the site absent in hereditary nephritis. People with hereditary nephritis do not develop antigenium disease. However, if they receive a kidney in with the donor kidney contain missing antigen, and they may present with fulminant antigenium disease. The immune complex disease that may also manifest as RPGN have low circulating levels of third compartment of complement secondary to focal or diffuse complexes deposit in the glomerular capillary subendothelial space. Certain of these disorders, such as SLE and cryoglobulinemia, can present with pulmonary hemorrhage and patients with cryoglobulinemia often have the low C4 complement and high rheumatoid factor, and the symptom may caused by paraproteinemia and the hepatitis C. Another cause of presenting RPGN but with the normal level C3 complement is a form of the IgA vasculitis, a syndrome of skin vasculitis characterized by the palpable purpura, gastrointestinal bleeding, arthralgias, and pulmonary hemorrhage. The C3 complement is detected on the kidney biopsy, particularly with galactose deficiency IgA1 and the mesengium rather than the capillary loop, and associated with the mesangial cell proliferation but not the low serum level C3 IgA, and diagnostic test for distinguish disease associated with this immune complex. Acute tubulointerstitial nephritis এখন আনসাবো